Hey, welcome everybody. Good to see everyone. We're running a little bit late, so we're going to go ahead and start. I'll get closer here, so it works out all right. Let's call this meeting to order. Friday, June 9th, 2023, Behavioral Health Coordinating Council. Approval of March. I think we've pretty much taken roll call as we would. Let's go to approval of March 10th council meetings minutes. Motion by Member Reese.
Second.
Second by Member Taylor. Comments or questions, additions or corrections? If none, all in favor, please say aye.
Aye.
Opposed? And the motion has passed. We're going to item 3. Well, we're losing two great members of this board. One of them was one of the mainstays, driving force, Judge Rob. You know, in the beginning of this, thank you very much for all your service and what you've done. And I know we have a very adequate replacement, Amy McFarland. Judge McFarland, thank you. So we've got another judge coming in who has a lot of experience, so welcome. Thank you very much. Also, I don't know if Diane is here, but Diane Schultz, of course, has done so much over the years with the baby fold and for the youth in so many places here. And I was just talking, I want to welcome Cleet Winkleman back into town, back here from Fargo. And he's assumed the role as the new director of the baby fold, and appreciate you coming in. Welcome. Look forward to working with you. Thank you. Next we have Susan, item 4, McLean County Bar Association. And Judge Foley, you want to say anything about this too?
Every year, the McLean County Bar Association celebrates Law Day. Law Day was established, I think, in the 50s, just a celebration of our profession, and it's been our tradition to award a person or entity in the community for their service to the community. In years past, the drug court was awarded that honor, and this year the recipient was this group, you all, the Behavioral Health Coordinating Council. And so I think Susan has the plaque, and so I'll turn it over to her.
Well, you just said everything that I was going to say. So that's great, because the best thing about accepting this award at the Law Day was I didn't have to give a speech, so that was the best part. But anyway, if Chairman McIntyre and Kevin, if you would like to come up here. Judge Pablo Eves did his remarks about the award to us, about the FUSE program, the triage, CIT training, and several other items that we've accomplished as BHCC. So this Community Service Award says, in recognition of meritorious service to the legal systems and citizens of McLean County, the Behavioral Health Coordinating Council 2023, McLean County Bar Association. And so this is also going to be memorialized in a permanent plaque at the Law and Justice Center. So if you go in the lobby there's the plaques of different awards that have been given out. So it's permanent there. So here you go.
Thank you. Take a quick picture right here. All right, yeah, Susan,
No,
you want to get in here?
no, it's okay.
No, all right. Here,
And here's the program that was.
Just want to say thank you for everyone in the judicial system, and all of you've done. Their cooperation has been really much appreciated in what we're trying to get it done. Thank you.
Do you want to pass it around?
Sure. Okay. Mrs. Schaefer is still up, as we're going to talk some about NACO and the Leadership Network. So I'll turn it back over to you.
Thank you. Okay, so I had a second peer exchange trip that Mr. McCall and I went on, and it was to Johnson County, Kansas. And you can go ahead and go to the next slide. So last meeting, I talked about Bear County, Texas. And so I did the same and different kind of thing as what's different and same about the two counties. And so here's some of the information. And that first item there, the integrated justice system, our justice system, and their gym system, we're like one of the 3 jurisdictions in the country that have had some kind of system like this. Now, theirs isn't quite exactly the same as ours, but it's very similar. But it also has more, too. So, and so they were also one of the initial jurisdictions for the Data-Driven Justice Initiative, which is now what this is called. So, their population is much larger than ours. And obviously, you can see that they're a much wealthier county than we are. They actually are the most wealthy county in Kansas and one of the most wealthy counties in the country. So there's a little bit of difference there. And then the same thing with Texas is that they don't have Medicaid expansion, where we do, but they're home rule. So there's a lot of differences there too, but there's a lot of similarities. Go ahead. Oh, okay. So this is just kind of an overview of one of the slides that they had about case managing Wally. And so you can see that there's many different entities that interact with this individual. And so the individual's like, where do I go? And all that, and then who's doing what? And there's no connection between any of them. Okay? So I have to say that back in 2015, right after we did the Mental Health Action Plan, I had been going, actually prior to that, I had been going to Johnson County, Kansas, didn't even know any of this stuff. And so in 2015, Bill Wasson starts talking about JOCO, Johnson County. I'm like, well, where's that? And actually, it's a suburban county of Kansas City. And so I said, oh, I go there every year. And so I went ahead and met with them. And there were 2 things that I learned about them. And one of them was the co-responder, and that's when I first learned about a co-responder model. And they had it in 2 of their 19 law enforcement agencies. And that's when I became the big proponent of that. Didn't happen yet, but The other thing is that they had this thing called My Resource Connection. And what it is, they take their data, because I'm all about data, and this is data-driven justice, data, familiar faces, and created this MyRC. And what it is, it's hosted by Johnson County, and it's care coordination. So later, Gloria is going to talk about care coordination, so I'm not going to go much into that. It's a form of that, a little bit different than what she's going to talk about, but very similar. So, so basically, it lets individuals talk, providers talk to each other, okay? And their focus is on the high complex utilizers that have very complex cases. So, go ahead. And so what they do is they look at the data, and they then get the people together and work on creating solutions for those people. And it allows them to share data between providers, which is some of the things that we have, or we're looking towards. So they also have the public-facing component, which basically is what our PATH database is. And you can go and look at that and see all of the different providers and whatnot there. And so they just created a frequent familiar faces initiative work group that actually goes, reports to the Criminal Justice Authority. There have not just, the county runs not just the law enforcement and stuff like that, but they also run their behavioral health center. So it's under the county jurisdiction. So they're looking at both criminal justice data and health data. So that's kind of different. So then they also did, so this is one thing I wanted to say about that frequent or familiar faces work group. I kind of looked at that as a combination of Fuse and specialty courts staffing and that kind of intense wraparound ACT-type services for those individuals that are very complex. So kind of a combination on that. So then, one of the things that they did, and if some of you will remember, back at our first forum, when former Administrator Wasson was talking about predictive analysis. They have used this data to try to do predictions as to who is going to need services or who's got trends that are going towards those more frequent interactions. And so they can then do earlier interventions to try to head off some of those interactions. So that was back then. So for those of you that remember that really deep stuff that Dr. Beck probably would really love to get into. So now they are looking at helping, getting more information to do more proactive. Like I said, it's cheaper to people at the beginning or early than it is at the end. So they're trying to be more proactive. So that's just the predictive analysis part. Next slide. Oh, for the 2022, go back one slide. For 2022, they expanded their access to the data to the public health part too, because their public health department, they actually have epidemiologists that actually look at the data and look at trends in that way to go more upstream to get more into the social determinants of health and work on some of those issues. And then Douglas County, they're the county west of Johnson County, and they have been kind of starting to partner together. They both have high suicide rates and high overdose rates. So that's what they're looking at with the data for EGG, the one last slide. And so DSSG. Anyway, so what they've done too is that Douglas County also now provides data for MyRC. They're part of MyRC along with 2 other counties, so that they can then utilize those same resources without having to create that themselves. But Douglas County's focus is more on the criminal justice and behavioral health side, whereas, Johnson County was much more encompassing. So about 10 years ago, they started thinking about what they wanted to do. So they went to Bexar County, Texas, several years ago and saw, remember Haven for Hope that I showed you last meeting. And so they came back and they had this nice campus that this design, came up with a design for this really nice campus, a little bit scaled down based on what they, their population. And then they found a price tag of $41 million. So that was kind of like out of the question. So they scaled it down quite a bit. And they created a treatment and recovery campus. And that is, which part of it it just opened 4 days before we got there. So anyway, but their treatment and recovery center is a combination of urgent care, CSU. There's on that campus is also their supportive housing and their transitional housing. And so that was, and that's right across the street from the hospital. So that when someone comes to the ED with a behavioral health problem and they recognize that in the ED, they go, no, don't come here, go over there, because that's the diversion. So they have a Sally port so that when law enforcement or EMS brings someone in there, they can come in that way instead of coming having law enforcement coming through the front door. So, next slide. And this is just about their housing. They do take, for their urgent care, they do take anybody, all ages, not just adults, it's youth included. They have an APN on duty 24/7 that will give them medications. So it's a little bit different than what we have in our triage, urgent care. So there's quite a few differences there. So, but that's kind of the concept there. Okay, next slide. So there's the funding on how they did that, and they did pass a quarter-cent sales tax to pay for the treatment center. That is by the county. There's also the funding that created the transitions in the cottages came from various different sources. So it wasn't just the county that paid for it or anything like that. They got it from various sources. Plus, they also had the land donated to them, which, is nice. It was like valued about $650,000. So that was pretty, significant. So, and then they took ARPA funds because obviously we have housing issues, or everyone has housing issues. And they took $24 million of their ARPA funds, which was a majority of it, and built a supportive housing unit for individuals, because that was a very big need apparently in that community. So that's pretty much all I have. I tried to talk fast and not bore you with my data stuff. Stephanie.
So I have two questions.
Okay.
First of all is more of a detailed question, and you mentioned that their urgent care center takes the full age range in one center. Were you able to see how they did that? Did they have them separated?
Okay, no, because they just opened, like I said, 4 days before. They were not taking people coming in the front door at that time. They were only letting them come in through the Sally Port because they're phasing in their opening. So I think that it was like a week ago or 2 weeks ago, they actually opened that front door part. And no, I did not see how they did that separation, because they're really, you walk in the door and it was like a reception area. And they had lockers for people to put things in. And then they would take people back into different consultation type rooms.
Sure.
So they didn't, but that's a good question. I have a bunch of follow-up questions for them, so
Okay.
that I can do that.
That would be appreciated. And my second question is more of an overview. So the purpose of these really is to kind of look at how other communities are kind of doing some of the same things we want to do. So how do you envision this fitting, or the information you gleaned here fitting in our behavioral health action plan? And how would you envision that moving forward? Like, what are you looking to do with this information?
Okay. So yes, the whole idea is to learn from others who have, and everybody's at different stages, They're just starting a recovery court in Johnson County. So you'd think that they would be really advanced in a lot of things, but yet they're not in other things that we are. So we have to look at these things and take them to see what's working there, and then how to tweak it, because they have different resources. All these jurisdictions have different resources than we do, and then tweak it to say, can that work here? Would that be applicable? So there are some things that aren't going to be. And so if you go look back at the Mental Health Action Plan, many of the things that I've talked about that I've learned through these trips and the other calls and just interactions with other electeds in different jurisdictions is that, where was I going with that? How it goes back. Oh, what do I see going forward? Okay. What do I envision? So that those things are possible. It's not that we're making things up that would be pie in the sky, never been done before things. we can do some of these things based on what we have, and then actually improve the whole community. So going forward, a lot of this is all about data, right? So what I envision, and I know I've talked to several of you just in some general terms, what I envision when it comes to that is to have, maybe get a very small group together to do just some brainstorming, like a little work group, and find out what some of the issues are and how, and create steps to move forward. Concrete steps to move forward to work towards some of that. Because if you look at the mental health action plan, that data map, if you look at the data map, there's a little TBD in the middle. Yeah, that's the TBD that we need to work towards. And so, and then also, I can then go back, I'm creating a list of questions to follow up on some of these, because I don't want to sit there and send one question when I have one, and then another question, and then another question, another question. I just want to create a whole list of questions to make sure that we're asking the right questions. And then we can learn from their lessons, the lessons learned from that they got, because like Johnson or Douglas County, when they went and wanted to create a haven of hope, it was not really feasible. So that kind of thing. So that's kind of how I envision moving forward. Anyone else? Thank you.
Okay, thank you, Susan. We'll go on to community updates. Kevin?
Yeah. Our first community update will be Gloria Sugg from CYFS.
All right, so I'm Gloria Sugg. I am with the Center for Youth and Family Solutions. I'm the program manager for care coordination. And care coordination, what it is, we provide intensive case management to youth and families. We just started in February taking cases, so we are brand new. Care coordination is a new program throughout all of the state, and we serve McLean, Livingston, and DeWitt counties. So most of our referrals come from McLean County. You can go to the next slide. So what do we do? So care coordination is a voluntary program. We have to get families to engage and buy into our program. So we have phases. Our engagement phase is all about building relationships and establishing trust, explaining that wraparound process. So our goal is to serve families where they're at. It's all about them and their process. So as we work with these families, we identify who they are working with in the community, what providers they're working with, and our goal is to collaborate and make it easier for the families to navigate all these different partners and community members that we have. So we have initial child and family team meetings, and depending if they're intensive case management, they have these child and family team meetings every 60 days. And then if they are wraparound, they have them once a month. So team meetings pull everyone in the team, family members, providers, whoever is able to come, and we develop our treatment plan. We work on updates, goals, crisis, all of those things. After that initial planning phase, we stay in that implementation where we are continuing these child and family team meetings, recognizing and supporting these families. And then once this program can last up to a year to 18 months, 9 months, however long the family buys in and however long they need our support. So once they transition out, we make sure that they have a plan, we make sure that they are doing well, and then we check in with them to make sure it is working. You can go to the next slide. So how we receive our referrals. The Office of Healthcare and Family Services, they pool score, CAN score. So CAN's assessments are completed by Medicaid providers. So these youth have to have a Medicaid provider that completed the CANs. So like a therapist or somebody in the community that would have identified a need. Based off of that score, once a month we receive these referrals. And then after that, if these families agree, we are responsible for those CANs assessments. And then we serve youth receiving Medicaid ages 0 to 21. Our referrals have been so far everywhere from like a 3-year-old to a 20-year-old about to age out. So we have all of the ages covered. Next slide. So how providers are included in care coordination. Current providers will be encouraged to attend child and family team meetings to provide CANS updates and work as a team when serving families. We are responsible for the CANs. That's what the HFS has identified. So we will work on those updates. If anyone has done a CANs assessment, it is very long. So our goal is to make it easier for treatment providers, for therapists, for people in the community. And so it's our job to keep those up to date, to work with therapists and other providers as to what their goals are and what their objective is, and make sure those are included in the CANs. And then, of course, we provide those updates to the therapist and the other providers using that. Next. Tell us what CANs stands for. Ooh, CANs. What does CANs stand for, Stephanie?
So she's referring to the Illinois Medicaid Comprehensive Assessment of Needs and Strengths. It
There
is
we
the
go.
state-mandated assessment tool for all Medicaid providers.
Yeah. And how the community, oh, did you have another question? No. Oh, you're okay. So how the community fits in. We work with therapists and other mental health providers to make sure those can stay up to date. We utilize funds to able to access therapeutic support such as art, music, and dance therapy. And then we also have individual support services funds. So we can access like art classes, sport classes, and other things. If we identify it as a treatment need, we include it in our CANs. We get funding approved by the state, and then we're able to provide those services to the families. And then, of course, we work on finding different community events, activities, and classes, really working to try to get those families involved. The goal of care coordination is to help families be able to serve themselves, help families be able to navigate this whole process that is mental health. Next slide. And so things to come. Care coordination is a part of a state system of care process. The hope and the goal is to have other services in the community that these youth can access. Therapeutic mentoring, intensive home-based services, and therapeutic respite. But communities have to buy in. They have to be open and willing to start these programs with support of HFS. And that is my PowerPoint. I know I talked really fast. Questions? Yeah. We only take Medicaid at this time. Yep. And so with Medicaid being, obviously with COVID, we also work with families to reapply for that process. We went through this whole training with Medicaid to be able to do that for families and with families.
I'd like to add some information
Oh,
that
yeah.
I think would be really helpful here.
Close to mine.
Sorry.
Very close.
Is that better? Yeah. Okay. So around the IM cans, as we were speaking, and Gloria was doing such a great job of kind of reiterating that once a youth is enrolled in pathways, our care coordinators become responsible for the IM cans for that youth. The state envisions the IM cans to be a single tool for all clients, that every provider working with a particular client is working off of that single plan. So it'll be really important, and one of the reasons we felt it was important for Gloria to share with you guys, those of you that are serving youth that are Medicaid, is that once a youth becomes enrolled in pathways, we are the only entity that can do that IM cans. And so we need partnership, we need collaboration and connection and communication so that that IM cans is comprehensive. It includes all of the perspectives at the table, and that it covers all of the needs that each of you as providers are serving. And that way there's no issues in terms of the state understanding what the youth both needs in terms of treatment and is receiving in terms of treatment. So the other piece I wanted to touch on is how important it is for anyone who is serving these youth to be at the table. There is a specialty service code for providers to be able to bill for attendance at child and family teams. So the state did take into account the understanding that we couldn't ask providers to come just out of the goodness of their heart. And so, you know, we ask and encourage that any of you that are serving Medicaid youth and billing Medicaid, that's kind of that key code, that you please let your teams know that they should be joining these teams and they should be attending, and we need them to be a part of it. Thanks.
Yes, you had talked about at the very beginning, the intensity of services is determined based on need. Are you using a specific tool to stratify those needs in terms of determining that intensity of service?
The state is using the cans that they receive from these Medicaid providers to determine that score, what they fall into. But what we're seeing is oftentimes people don't score very high because, that means these families need more than we might be able to offer. So we assess that in the beginning, and then if we identify that the family needs to be moved up in a tier, then we make that change within that first 14 days.
And is that just based on?
That's based on the CANS assessment, so it's like 52 different questions that are assessing
Right.
what they might need and all those.
So
those
you're
kinds of
using the
things.
cans to do that stratification?
Yeah, we're using the
Okay.
CANS.
The state uses the IM cans to stratify.
It's a very data-driven type of program. We have assessments that we have to do. We have tools that we have to use through the University of Illinois that's also working with the state to implement this across the state and make sure everyone's on the same page moving forward with this program.
I don't have a question, but I want to just make a comment about how this actually is very similar to some of the things that Johnson County is doing and their care coordination and how this is where everybody's going. So and the state's leading this one, but I think that there's a lot of similarities and as to how this is going to eventually come out, kind of thing, to be able to work with Stephanie or you to get some ideas to do the bigger picture.
Yeah. So my background is I did this program in West Virginia, and they started with care coordination, and then they started with crisis support. So it's something that they're doing across the country, care coordination and implementing.
Are you guys looking for partnership to help with the IM cans, the therapeutic pieces after? Because we do all of that as well at Mark First. So I'm just wondering if there's any way we can help.
You know what, Brian, I really appreciate that. You kind of segued perfectly into my next ask. So in terms of the IM cans, there is an occasional need to have a provider that we can refer someone to who would like to see if maybe they're eligible for pathways, but are currently seeing a provider that doesn't do the IM cans. So that could be a way we could look at a referral process there. Most of those youth are working with a private practitioner that isn't mandated yet to do the IM cans, so they probably wouldn't be looking for ongoing services, just someone to do that cans piece. What we really, really need are child and adolescent and youth and family serving entities that are willing to look at the other home and community-based service array that Gloria mentioned. The therapeutic respite, therapeutic mentoring, and the intensive home-based service array. Those are services that, due to federal expectations around care coordination, are not supposed to be provided by the care coordination entity, right? So as much as I want to build those programs so that we can just provide the full set of services, we're not supposed to be that because we don't want to have that conflict of interest, that kind of self-serving referral system. And that's the reason behind that conflict of interest. So that's why we need to partner. We need agencies like yours to say, maybe we can do that, or maybe that's something that we can fill. Another piece that goes along with the Pathways program that I think is missing in our community and is really important is the family peer professional piece. So there is an actual service under the home and community-based service array for family peers, so parents who have been through the system with their own children or foster children, cared for a child with behavioral health needs, who can then help these families go through the process, empathize with them, provide perspective and hope, and all of those pieces that peer support can really be useful for. And our community just doesn't really have family peer providers. Unfortunately, all of the home and community-based service array has to be provided by a Medicaid entity. So.
We have a comprehensive assessment team, CAT grant, that is nearing its completion and is closing out. How would you see this program intersecting with the work that was started through the CAT?
Sure. Well, what I would say is McLean County was ahead of the curve. The CAT grant came out of a pilot that the providers had pulled together and said, hey, let's try this. And so we were doing care coordination through CAT before the state actually even came out with pathways. Right now, I believe the overwhelming majority of those youth referred to CAT have already been referred through pathways and deemed eligible. And those that have not yet, the belief is that they will be eligible based on the IM cans that Donnell, our CAT coordinator, is doing for those youth. Now, that is Medicaid only. So what that leaves out is youth who are not publicly funded. So youth who may have private insurance or be uninsured altogether, which is a small number, but it does occur. And my understanding is we're still waiting on the SOC grant feedback. And if that particular grant is awarded, that would fill that need. That would cover the privately insured youth or the uninsured youth.
Okay, thank you, Gloria.
Yep, thank you. And if anyone wants a flyer, I only brought 15, but feel free to take one, and then my email address is just gsug@cifsolutions.com. Feel free to email me if you'd like to connect. I'll probably call to you, so feel free to give me a call back, and then I can talk to you more. Thank you.
Great, thank you. We're going to move on to our second community update item, which is for the Behavioral Health Urgent Care, or BHUC. Kim Fryman and Joan Hartman had prior obligations today, so they asked me to provide a brief update. And I'm happy to announce that they are finally getting to fully staffed. There's been some hiring issues in this community, especially for some of those case manager positions and those crisis type of positions. And with some of the new graduates at ISU and IWU, they are just waiting on some final paperwork to go through. And we're hopeful that they'll have the expansion of hours going from 9 a.m. to 1 a.m. Monday through Sunday. Kind of opening it up more to what our McLean County Triage Center previously was. Kind of in conjunction with that rollout of the new hours, you'll start to see an expansion in some of the marketing for that program. And that's going to include their website and social media, but also you'll see around town advertisements on Connect Transit buses. There are 3 different billboards in the community. They're going to be in Healthy Cells magazine. They're doing interviews for BHUC. And most importantly, they're going around and talking about it a lot more with our community partners, pushing it to those folks that work in the realm of crisis. And really starting to get the word out there that this is a community service that can be utilized by anyone over the age of 18 in McLean County. And we're really hopeful that we'll start to see that utilization ramp up and get to the numbers that Triage was really starting to get towards the end of its tenure. Do we have any questions on behavioral health urgent care? Okay, we're going to move on into our next community update item then, which is Bridge Academy from the Regional Office of Education and Mr. Mark Jontry.
Thank you, Kevin. I'm pleased to come and kind of give you a summary of the first year of the Bridge Academy. By and large, it's been a very successful year, and we've seen a lot of gains with the kids that we were able to serve. In total, we had 33 students, grades 7 through 12, come through the program at some point through the year. As we finished the school year in May, we had 18. And so as kids cycled through the year, and when we finished up last month, we had 18 that were currently enrolled. Just as a reminder, we serve kids in grades 7 through 12, and about a third of those had either an IEP or a 504 plan. So 2/3 of them were just students who otherwise did not have any identifying supports necessary when they came to us. And so as a result, in some cases, we did, as kids spent their time with us, if they transitioned back to their home school, some of them did end up with 504 plans as a result of their time with us. And we had 1 or 2 that ultimately did end up getting identified for special education services. Just kind of a summary of how, of those 18, of the other 15 that either are no longer in the program. Some of the reasons for that, we had obviously some successful transitions back to their home school. We had a few that moved out of the area, and so no longer in the service area. We did have a couple that did get hospitalized or also were referred to residential. I can think of one student who was with us for 2 days, and the staff quickly identified that they were a residential candidate and facilitated that. And a couple others were recommended by their primary care physician to be to stay at home, homebound for medical reasons and could no longer join us. And then we had a couple that chose homeschooling and got jobs, and which was a win as well, if that's what was best for that student. So that was kind of the scope of why kids either transitioned back to their homeschool or any other of those dynamics that were in play. Our partnership with Mark First was very, very successful, and I want to thank Brian and his team for allowing us to get this started. Being located at Mark First allowed us to provide some programming on site. We leveraged a pediatric occupational therapist one time a week to meet with our students in a group setting to kind of get some of their sensory-based regulatory techniques down, and so that was very, very helpful. So they really enjoyed their time with Miss Hannah. One of their transition team specialists also came over one time a week to observe and partner with the students who may be struggling with finding preferred seating, how to engage better in their academic work, and things like that. So that was very beneficial. This summer, as part of our summer school, we are partnering with the Illinois Art Station to provide that enrichment for our kids. We actually have a total of 10 of the 18 are attending our summer school. That is elective. It was not a requirement, but that's a good number. And some of the other 8 that could not was because of some family dynamics, vacations, things like that. So, but we're really excited to have 10 of the kids continue over the summer. When we look at our parental support to help the parents better support their kids, we offered a couple of newsletters a month with tips and tricks for them to help support their students at home. And then we also did Zooms with support groups, and that was very, very helpful. A lot of our parents came back and said that really helped them know that they were not alone in dealing with the issues that they were having with their students, their children. And so that was very, very well received by our parents. As we look to next year, there are some changes that we're going to make. Certainly, our attendance rate did improve for all of our students. The average attendance rate for all of our students was 23% when they came to the program. When we ended the year, it ended up being 61%. We were as high as 80 in about midway through the year, but as we got into late spring, some of the attendance rates fell off for some of our kids. So we're looking at examining some of those strategies of what we might do differently for that. We had a lot of asks for 5th and 6th graders to be referred to the program. We did not set the program up to serve 5th and 6th graders this first year. So we're going to drop down and serve 6th graders next year. We're holding off on the 5th grader ask at this point. At the same time, we didn't see a whole lot of seniors, which probably isn't unusual, honestly. I would expect that most of the kids we would see, it would occur early in their high school career by and large, and so that wasn't totally unexpected. We did have a minimum enrollment range of 60 days. We are going to bump that up to 90 days because we did see the majority of the kids that stayed and were successful. They were with us 120 to most of the year if they didn't otherwise successfully transition back or some of those other reasons. So we'll be doing that. As I said, we right now have 18 kids that'll be with us to start if we were to start the fall tomorrow. But I will tell you, I guarantee you, we will have referrals rolling in as soon as registration starts in August. So my anticipation is we'll probably be somewhere between 22 and 25 when the first day of school rolls around, and we'll probably be close to 30 halfway through the fall. So By and large, I think it was a good first year, things that we learned, things that we're going to do differently to try to improve. But with that, I'll take any questions anybody has.
I have a question. Yeah, I've heard great things too about the school from students and parents as well. I had two questions. Is the primary referral source still from the schools? Is that
It
how
is.
you're?
It is.
Okay.
And the reason for that, the schools are paying part of the tuition for that. But that also just needs to be the process that we follow to engage the schools. Now, Tricia will get a lot of the calls from the parent. A lot of times, the parents are the first ones to reach out. And so she does talk to them, but then redirect them back to the school. And she will also then call the school administrator to let them know that she's had a conversation. But ultimately, it rests with the home school.
Okay, perfect. My other question was, is the Illinois State Board of Education, is that who is paying for residential for the two students?
Depending on the individual student, that would be, I don't know the specifics. I could find that out for you, Lisa. Because what we would do in that case, we would unenroll them back to their home district, and their home district would follow that enrollment like they typically do.
Oh, okay.
So
Just
that'd be
curious,
my
the
guess.
residential funding sources are always
Yep.
good info, so thank you.
Yeah,
Thank
that
you.
would fall back to the home district.
Okay, that makes sense. Thanks.
Susan?
Can you remind me what your capacity is?
At fully staffed, we could serve 40 students. And when I say fully staffed, we planned for 4 full-time teachers. Right now, this year, we had 3 based on the number of kids that we had.
So would you have to increase that if you take the 6th graders and then potentially, eventually, maybe 5th graders? Would that have to then be increased?
So we're going to kind of just see how the enrollment numbers go, honestly. I'm not that worried about it at this point relative to serving the 6th graders in that dynamic. We have them in separate rooms. If we really got to a point where we really had to grow, that would obviously be an interesting problem to have, but it's not one that concerns me in the near future.
I'm interested in whether you've got any students that are recycling and coming back through the program again. Is it one and done?
We would not treat them as one and done. So I'm not aware of any that transitioned back, or probably there might have been 1 or 2 that I can think of that started with us and then maybe paused.
Yeah. Maybe ready to come back.
But could be ready to come back and that. So it would not exclude them. We did have one that I can think of that just generally had a medical issue that they were out for a while, but that they came back when they were able to. So,
But still need your care and when they can physically handle it.
yeah, that would not preclude them from coming back if everybody was in agreement for them to transition back and it didn't work and everybody said, let's go back. So,
Gotcha. Thank you.
If you haven't had an opportunity to go out there, that's an interesting program, quite a facility. Cassie and I went out and took a tour, and it's just such a innovative and progressive type of a program, and the progress that they've made is amazing.
Thank you, Chairman. I meant to say that, offer that to this group. If you have a desire to come out and take a tour, just either reach out to me or Tricia, and we can arrange that.
All right, so finally we have number 7, McLean County Initiative updates. I'd like to share a couple of updates about the Department of Behavioral Health Coordination specifically, and then also a quick reminder about our Mental Health Action Plan work groups. I want to thank our speakers and presenters today for their expediency. This is probably the first time that we will actually finish this meeting under the time, and so thank you very much for that. For behavioral health coordination, we're happy to have finally added 2 new staff members to our team. The first being a position that I discussed in our last quarterly meeting, which is a grant writer / grant manager if we get the Systems of Care grant, in Mr. Tony Jones. And I'm happy to say that he has hit the ground running. He's already been asked to work on several grants, one of which is our Family Treatment Court grant with the judges and Mr. William Scanlon, and that's going pretty well so far. So really excited to see what Tony can do for the county, what kind of funding he can bring in, and what other kind of collaborative projects we can bring Tony in on to bring more finances into the community. The second person that we have joining our behavioral health coordination team is actually a new Fuse case manager. We had planned at the beginning of this year to hire 2 new case managers to expand and compound on the success that we've had with our Fuse program. And we've really taken our time to find the right person with the right skill set who can really get into what is a unique care coordination team in Fuse. And so we have Alicia Mouchon with us here back in the back here. Just wave and say hi. I'll embarrass her a little bit. This is her first week, so please don't ask her too many questions. She'll be training for a while, but we're really excited to get her started and start serving more people through the Fuse program. The last thing I have to share really for behavioral health coordination is 2 changes we're making in some of our services. Soon there will be an RFP issued for what was formerly our telepsychiatry and prescriber services through Genoa Telepsychiatry. In one of 2 moves, an effort to make some of our expenditures as local as possible. We'll be looking to partner with some local organizations for those services, and I've already determined that there's some interest, and the ability to do that is certainly there. So I look forward to that in the next couple of weeks. The other kind of change to what we've historically been doing is for our behavioral health forum. We've decided to move forward with having that at Illinois State University this year. Our behavioral health forum planning meetings are ongoing. They're weekly every Wednesday. So if you would like to be a part of that, if you're not already, please reach out to Sarah Stalter to my right here. If you'd like to have a little bit more input on what those tracks and sessions are going to look like. We're very excited. We did a tour recently of ISU and their new updated Brown Ballroom, and we're very eager to get in there this year. We think it's going to be bigger and better than it ever has in the past. So really looking forward to that. For our mental health action plan groups, we currently have 5 ongoing meetings. Those are our youth, justice involved, access to medical services, crisis, and housing meetings. Some of those have just kicked off, but some of our more mature ones are into their 4th and 5th meetings now. And so I'm really looking forward to, since we've set the stage and going through and reviewing some of the goals in the mental health action plan, finally getting some actionable items for us to collaborate on. And so the last one that we'll be rolling out for those that kind of is in conjunction with the data piece that you've heard Chairperson Susan Schaefer talk about a lot is our collaboration and coordination work group. And so details about that should be coming out fairly soon. The next round of invites you will get, I'm happy to say as well, will be reoccurring invites, so we won't be changing the dates. We've kind of locked in a time that I think will work for the majority of individuals. Again, if you're someone who is a BHCC member that has interest in attending these groups and you can't make it, you can always have someone there to represent your organization and to provide feedback and give their expertise to that group. Since we have a little bit of extra time here, I'd like to ask Jackie Mathias to come up here. I was originally going to have her on this agenda, but I was really uncertain that we were going to make it under the time. And so I'd like to call her up just to give a brief update on some of the great things the jail is doing in relation to behavioral health. Yeah, please go ahead.
While Jackie's getting settled, I would like to just remind people that we have lots of work groups that will be pushing the ball forward with really strategic planning and action steps for the mental health action plan. We realize there are a lot of meetings and a lot of work groups around this work. So Kevin has been very intentional in making this very inclusive and including people on the BHCC as well as other community members that have expertise and wisdom in the areas that we are trying to create change. But we also understand that as we hone in on some of these actionable steps, those work groups might become smaller. So don't feel that you have to attend every single work group. Do not feel like if you're not coming and you're sending someone else from your agency that might have more expertise in the specific topic at hand. I think Kevin and Sarah are really going to start honing in on topics, and that will help you all decide whether your presence is necessary at a certain work group and help you for planning, because we do recognize you have your own jobs to complete. And so we want to make sure that we're honoring that as well, and the commitment that you've made to the community in serving in this way. So when we get more topic centered, it'll probably shake out a little bit better, and you'll understand where you can give input. So thank you for that, and thank you for helping us through this transition of these work groups.
And if I might jump in, as I have for many years, I'm a grumpy old man here. The goal is implementation, and the more we can get started and done and off the ground and having everybody involved and contributing is really why we're here. Thanks.
Maybe, okay. I just wanted to give some updates on inmate services, because I know there's a lot of confusion a lot of times on what we actually do in the jail or don't do in the jail, and a lot has changed since I started. When I started in 2009, there were 2 of us in inmate services, and we didn't really do behavioral health much. But now, over the last several years, we've made a lot of changes and expanded. When I began, it was 20 hours of counseling that was contracted through an outside agency. In 2016, we added our own full-time licensed therapist, so that's 40 hours a week with a licensed therapist. In 2021, we added a dedicated case manager reentry specialist, and her entire job is pretty much coordinating linkage and care and providing resources, and she has expanded how many people and how many agencies that we are able to work with now. This year, we added a second full-time MSW counselor, so now we have 2 full-time counseling sessions. We have, in July, we are increasing our psychiatric hours. Currently, our psychiatric prescriber is at 5 hours with us. She is increasing to 20. So we are adding 2 of those days, 2 5-hour mornings will be for mental health, for returning patients, and then also new and emergent ones. And then one of those days we're dedicating to medication-assisted recovery for our substance use disorder treatment, because she is a prescriber for that as well. So we're very lucky to have all of that. In 2019, we opened our special needs unit to address some of the population and integration issues for our individuals that are incarcerated with some behavioral health challenges that don't allow them to be in general population most of the time. Our program director has increased some of the things that she's providing for the overall mental health of everyone and behavioral health of everyone there, including adding different kinds of games, art activities. She has new special eye bags every few weeks for our indigent population that normally would not get extra above what we normally have. Our entire female population gets new bras every 2 to 3 months free of charge, because that's just something everyone needs when you're in there. We've also increased our treatment of those who are found unfit to stand trial or not guilty by reason of insanity. Unfortunately, every single year it's been increasing how many people are found unfit or not guilty by reason of insanity. In 2020, we had 16 individuals found UST or NGRI, and all of those people were transferred to a state hospital. In 2021, we had 20 people. 3 of those people we were able to provide treatment in the jail and not have them sent to a hospital to shorten that time. In 2022, we had 27 people found unfit or not guilty by reason of insanity. 5 of those were found fit without transfer, and 2 NGRI were released to community support instead of going to a hospital first. This year, we have already had 15 people found unfit or not guilty by reason of insanity. We've had 2 found fit so far without transfer and 2 NGRI released to the community. So when we do that, given how long it takes, because it's months and months before someone goes to the hospital, we're trying to shorten that time and be able to get them through the legal process and moving on with life. Coming up soon, as I said in July, we're increasing our psych provider hours. We're also starting our MAR program so that we will be able to do that. With our MAR program, we have already partnered with Chestnut. They're having it's called J-Coin, and I don't know all of the letters. It's Justice Involved People with Opiate Disorder, basically, to provide warm handoffs, basically, to link them to further treatment in the community. So that we can make sure if we start it with us, it'll continue when they get out. Our case manager is training to be CADC certification eligible, so we're hoping to have a certified addiction counselor very soon. Our MSW counselor is already applying for her LSW, so I'm hoping to have a second licensed person soon. We're working to have a more consistent therapy dog program. We've had that come in before, and so we're trying to work on a way to have that. And also I'm working with a community provider to see if potentially we can start an art therapy program as well. That's quick, and if you have questions, but.
Jackie, will you tell those who might not know what MAR stands for?
Medication-assisted recovery. So that is our individuals who are struggling with substance use disorders. It provides medications such as naloxone, Suboxone, Vivitrol, various others to
Okay, thank you. Okay. Well, that pretty much wraps things up. I just want to make a comment. I noticed during today's meeting, and I want to compliment those of you who have reached out to interact and work together and offer assistance to other organizations as we try to put some things together down the road. I really appreciate that. I want to, again, welcome our two new members, Judge McFarland and Mr. Winkleman. Glad to have you aboard. Thank again for those of you, including Beth Robb and Diane, for all that you've done to contribute to this program. Our next meeting date is Friday, September 8th, 7:30 again. Friday, September 8th. You have it down. Appreciate it. Good to see everybody. Have a good day. Meeting's adjourned.